All right, so the last module here of these rapidly acting agents for anxiety, we're going to kind of do a grab bag here of the leftover things. So things that attack approach norepinephrine, the sodium channel agents, also known as the gabapentinoids, histamine, melatonin, orexin, and finally cannabis. So we can think of these as sort of alternatives to benzodiazepines, perhaps. So returning to monoamines again, briefly here, norepinephrine being, of course, the primary neurotransmitter of the sympathetic nervous system, gives us some opportunities to manipulate that in order to change the experience of anxiety. Now, this is mostly done through drugs that are repurposed from blood pressure treatment. And so things like propranolol, which is a beta antagonist, this is going to be helpful for blocking some of the somatic effects of anxiety. So shaky hands, quavering voice. So often can be used in very low doses to help people with those kind of more somatic experiences of anxiety. Particularly, I've found this useful with performers. I've had musicians that will take this before a big performance so that their hands don't tremble. Um, but it's not going to necessarily change what's happening inside your mind with regards to anxiety, but you're not going to have that shaky feeling that you might when you're having anxiety. Clonidine is one that's used particularly a lot in children for kids that have PTSD. You see a lot of clonidine being used. It's dosed in these fairly small doses, 0.1, zero point 0.2 milligrams twice a day. It's one that has to be tapered off when you stop it because you can get a rebound hypertension when that agonist is taken off. Um, yeah, clonidine a strange drug because it's an antagonist at the periphery, but an agonist in the central nervous system, which is why, if you recall, we use it for treatment of ADHD. Dexmedetomidine, I'm not sure where that's going right now. This was recently put out on the market as a rapidly acting medication for agitation, but kind of oddly, it was packaged in this sublingual film, I guess, to prevent people from cheeking it. But it also means that you have to put your fingers near an agitated patient's mouth, which I suspect is not going to have a lot of uptake. And then prazosin we use a lot in treatment of nightmares. So this is an alpha 1 receptor antagonist that is taken at bedtime, usually in escalating doses. So you start off at like 1 milligram at bedtime. You don't want to start at a high dose because you can cause orthostatic hypotension, and you taper up until nightmares drop off. So we do a lot of this at the VA. Typically, I see doses, anywhere between sort of like 5 to 15 milligrams of prazosin in that, at least in that veteran population. Gabapentin is worth mentioning here because while it's not a benzodiazepine, and it actually doesn't work on GABA. It's confusing. So it works on these alpha 2 delta subunits of calcium channels. Sorry, I think I said sodium earlier. I meant calcium. And it actually doesn't work directly on GABA. So it's confusing. The reason why this has such an association with anxiety is because when this came out as Neurontin, like 30 years ago now, it was widely marketed for all sorts of things. It was a mood stabilizer, it was used for chronic pain, and it was also purported to be an anxiolytic drug. And, we tend to like things that are not benzodiazepines, so it was like, let's try this instead. And what ended up happening was that there really wasn't a lot of evidence for it. And the federal government came after Pfizer, who was the manufacturer at the time, because they'd said, hey, look, our Medicare system has paid for a lot of these prescriptions, and there's no evidence for them. So we want our money back. And they actually got a almost $500 million settlement. Kaiser did kind of a similar thing. But it's fascinating because the reputation of this as being an anti-anxiety medication has never really gone away. Now, what's interesting about it is that there is actually increased risk of death when this is co-prescribed with opioids. And the reason for that's not totally clear. It may be that, when you slow down the gut with opioids, that you get more gabapentin absorption. But there's a lot of co-prescribing of benzodiazepines with opioids because they're both used in the treatment of chronic pain. So while a lot of people think of this as a fairly benign med, there may be some risks, especially when you combine it with opioids. And most of the data is really not that great. So this is lots of different studies have looked at this. You can see, very little separation away from the to the left of that central line in this forest plot here. So, why do we keep doing it? And I think partially it may be an active placebo. It has enough of a mildly sedating, maybe somewhat useful in insomnia, because it just a little bit makes you a little bit drowsy, but it's just, it sort of refuses to go away. It's certainly not a mood stabilizer. So let's be very clear about that, prescribing this to patients who actually have bipolar disorder, I think is irresponsible because it has no efficacy as a mood stabilizer. And I think it has fairly minimal anxiety reduction evidence as well. Now, pregabalin, which came along after gabapentin, so that's Lyrica, actually has better data for anxiety. So this as an approval in Europe, the European Medical Administration, EMA, so the FDA equivalent in Europe, does have an approval for this. It didn't make it in through the FDA when they brought it, about 20 years ago. But there's probably better data for this working than gabapentin. So they're both cheap, they're both generic. If you're going to use a gabapentinoid, I would suggest using pregabalin over gabapentin. Now let's talk a little bit about insomnia because many of your patients, if not all of your patients, are going to have sleep problems. So the first line of treatment is let's figure out what's going on. Let's figure out if there's somewhere where we can troubleshoot. Can we reduce your caffeine? Is your sleep all broken up? Are you having sleep apnea? Definitely want to look at that. CBTI has increasingly good evidence for treating insomnia. That's the I is for insomnia. So lots of different things. You can use a standardized scale here, the PSQI, Pittsburgh Sleep Questionnaire Inventory, I think it is a good standardized scale, kind of like a PHQ-9 for sleep. And then we got to separate, is this a primary sleep problem, which is that is, say, one that doesn't have a psychiatric disorder. We generally don't see many of these folks in our practices because we're mostly dealing with people that have secondary sleep problems. So their sleep problem is coming from depression or anxiety, or PTSD. And definitely want to put a strong encouragement here to get sleep studies done. So if you have any suspicion somebody has sleep apnea, get one of these sleep studies done. They can be done at home now. You don't have to come into a sleep lab for simple sleep screening. They wear an Apple Watch type thing that measures their respiratory status and their oxygen saturation and their movement, and can reasonably identify sleep apnea in an outpatient type setting. But it's amazing how many of us, self-included, don't have good sleep hygiene. We're waking up at different times of the day. We're biggest culprit here is we're on our phones until right before we go to bed. And that bright light, if you remember, is suppressing melatonin. And then we can't sleep, and it's this vicious cycle. So we have a bunch of caffeine that disrupts our sleep. We take naps, that disrupts our sleep. I always tell patients naps are like a sleep snack. So, when you go to bed, you want to be sleep hungry. If you have a sleep snack in the middle of the afternoon, you're not going to be as hungry. And so you really want to try and restrict naps as much as possible. But really, think about getting that sleep apnea looked at. This is a great book from Matthew Walker over at UC Berkeley. Very useful patient education information. So if you are going to use a medication for sleep, think of them as second line treatments because education and CBTI are really first line treatments. Trazodone is pretty much my go-to for simple insomnia. I think you're familiar with trazodone. It's an ancient antidepressant, but useful for sleep in low doses, as is doxepin. So at these doses of doxepin, like 10 milligrams, you're not seeing much of an antidepressant effect at all, similar to trazodone at 25 milligrams. You're not going to see an antidepressant effect, but they have this antihistamine sedation quality. If somebody has depression as well, I'm thinking about mirtazapine. I did put gabapentin on here despite my earlier precaution because I do think it has some utility as a fairly benign sleep medication. Although its data is kind of marginal. And then, what I would probably actually start with is melatonin and then trazodone. So trazodone might be second, melatonin might be first. Many of our patients will have tried this already because it's over the counter. And then if those things don't work, then we start thinking about these sort of third line agents. So your Z drugs like zolpidem, your benzodiazepines. This is a place where a benzodiazepine might be useful. Antihistamines are another place where somewhere between second and third line. Lots of our patients will have used PM type drugs, Tylenol PM. The PM is diphenhydramine or doxalamine, which are antihistamines. Hydroxyzine is a prescribable antihistamine, and then quetiapine. It can be useful, especially if somebody has a secondary insomnia that is secondary to like mania or some sort of psychosis process. We used to use a lot more quetiapine kind of as a general hypnotic, and I'm not a huge fan of that just because of the potential metabolic risks. And then specifically if we're dealing with nightmares, then prazosin can be quite useful, as I mentioned before. Histamine, as talked about just a second ago, diet, uh, Benadryl is probably the most well-known centrally acting antihistamine, histamine inverse agonist, and obviously used for kind of allergic reactions, but is useful for mild sedation sometimes. Lots of people do this over the counter. Hydroxyzine, which comes in two forms, just to be a little bit confusing, Atarax and Vistaril, is a prescribable version of that as well. You want to be careful with antihistamines with older people because of the risk of anticholinergic side effects, cognitive issues. Similar to benzodiazepines, probably taking centrally acting antihistamines in an older person is really not great for cognition if taken chronically. So you just want to be careful, especially as your patients age, to be careful with these sort of sedating antihistamines. And melatonin, as I mentioned before, it's actually a hormone. Our bodies produce it. So when we take exogenous melatonin, we're just sort of adding to that melatonin availability. And this is created from serotonin. So serotonin is degraded to melatonin, and it really tells our brain that it's dark out because we only make melatonin when it gets dark. And this is why having bright screens on your eyes right before you go to bed is really not a great practice because your brain doesn't know the difference between daylight and a bright computer screen. And so as long as there's a bright computer screen on, it's suppressing the release of melatonin, which is going to make sleep more difficult to initiate. Many people use melatonin when they travel or for shift work because it helps to entrain the body to the natural night-day cycle. There are some melatonin agonists, obviously there's over-the-counter melatonin, but then there's Ramelteon, which is a prescription M1, M2 agonist. And agomelatine is not available in the US, but that is a drug that is in Europe that has an antidepressant property as well as being a sleep medication. There's a new group of medications on the market for sleep that actually do not work on GABA and do not work on histamine. They work on the orexin system, which is also sometimes called hypocretin. Orexin is there's only a handful of orexin receptors. They're pretty much all at the lateral hypothalamus. And what these do is these stabilize wakefulness. So you can imagine that blocking that would actually destabilize wakefulness, i.e. induce sleep. These are also the neurotransmitters that are probably involved in narcolepsy. So that kind of makes sense as to why some of these orexin antagonists, such as surovexan and lumbarovexant, can sometimes have side effects of causing these sort of narcolepsy type symptoms. So like sleep paralysis or parasomnias or having hallucinations as one is falling asleep. The nice thing is they don't have respiratory depression. The downside is that they are expensive and usually off formulary in many systems. And then finally, cannabis is something that a lot of patients will come to us having already adopted as a practice to helping them with sleep. It does, depending on the strain and the composition of the cannabinoids, there can be some sedating effects to cannabinoids for some people. It's kind of idiosyncratic. Some people find that they get drowsy off them, other people not so much. But this is a place where I've kind of chosen to pick my battles. I mean, I think the evidence for cannabis around sleep is somewhat mixed, but definitely it appears to reduce people's anxiety around their inability to sleep, and that probably makes the misery of not being able to sleep more tolerable and or less odious. And so for an adult patient, somebody whose brain is fully formed and they're, past their early 20s, who does not have a substance use disorder, does not have a cannabis use disorder, this is a place where if somebody's taking a couple of puffs off a vape pen right before they go to bed, I'm going to pick my battles, honestly. So, if they don't have a psychotic disorder, obviously also would be another place where I think this would be contraindicated. But, it's not an unreasonable thing for people to consider if they don't have those contraindications. And then finally, when thinking about other conditions, like if I've got a patient with depression and insomnia, I'm going to think about mirtazapine. Somebody comes to me with hypomania and I'm trying to get them some sleep. I'm going to think about maybe a sedating dopamine blocking drug like quetiapine as a means of helping them get some sleep. I'm also really careful to talk to patients about what is a reasonable range of medication to take on this, because insomnia is such a miserable experience that many people will say, well, one didn't work, so I'm going to take two. And that might be fine, but you want to have that conversation up front. You don't want people doing that kind of experimentation on their own. And of course, you always want to tell people to avoid taking these medications with other centrally sedating medications such as opioids, alcohol, and benzodiazepines. So I hope this is helpful, and let's take this up in the discussion. What made sense, what didn't make sense, and what needs greater explanation. Thanks for your time and attention. Bye now.